I want to introduce Dan Aune to you. Dan and I go back a ways. We worked together some when he was doing a gig with or Open Mind, Monica Oss's group several years ago, and we did a little bit of work around some managed care issues together. And then Dan helped with a project that we were doing up in Alaska. I think it was in Alaska, wasn't it? Yeah, in Alaska we were doing very early in my tenure, which he's now the executive director of Mental Health America Montana, and then also does a considerable amount of consulting work. And we've been working a lot lately around issues of looking for ways to enhance services, as I said last night, on providing services and really strengthening the ability of tribes to deliver and manage mental health care for their people. And so I invited him to come and talk to you. Certainly most of your jurisdictions have some significant populations of First Nation people. And so I'll throw this over to Dan to share about some of the work that he's been doing and how it might be applicable to some of the work you're trying to do.
Thanks, Dennis. Thank you for giving me some of your time to talk about some of the work that I've been doing. I wear a couple of hats. I run an advocacy organization, and which is sort of really close to my heart. And I grew up on a reservation, so consulting with Indian country is important to me from a lot of perspectives. I'm non-native, means I've got to see a lot of things from a non-native perspective. And I remember the first time I was a non-anything. I was in Denver. I came here for a housing meeting. I just opened up an urban Indian center in Fargo, North Dakota, and wanted to have housing in that. And it was full of native participants. And the guy up front says, well, does the non-native want to say anything? And I just sat there because I sort of went over me. And the guy next to me, he says, that's you, buddy. And so I got to sort of jump into it that way. But this is an endeavor that I think is an opportunity for states, both in terms of mental health, substance abuse, and Medicaid. And an era where we really have an opportunity to help states save some money around Medicaid. And so I wanted to 10 quick slides, some talking points, talk a little bit about my last 4 years of doing this work pretty significantly. And let's see, get through this. Oh, that's the pointer. Okay, here we go. So really what's important to know about this is that there's some things happening in the world where I think that tribal communities is how I refer to them. And they might be Indian nations. There are 565 federally recognized tribal nations. A good number of those are in Alaska. Some are reservation-based. Some are communities that are spread out in Nebraska. Was just there. They're all over the place, don't have a reservation, but certainly have communities. To urban communities or urban settings. The Mashantucket tribe in Connecticut, who had a big casino. The economy went down, their whole world began to change, and now they're families who need Medicaid in order to get services and are looking for ways to provide services and get services from people who look like them and have that shared life experience. And the state in which I live in Montana, a lot of the providers are non-natives. It's reservation-based, and many of the communities that I've gone and worked in, it's often that case. Even if it's Indian Health Services, it is non-native contract providers in providing the services who go to the setting and leave the setting and don't live in the community. So there have been a lot of what I would call roadblocks towards being a sovereign nation and wanting to determine the kind of care you give with the folks who you grew up with or live there who have that shared experience. So there are roadblocks with this, but there also is opportunity here. And I have about 20 communities, everything from urban settings, Detroit, Wayne County, City of Richmond, Urban Trails, San Francisco, Blackfeet Nation, is on the Rosebud Nation in Southwest South Dakota, New Mexico, Pueblos. Just was in your community, your country in Pendleton with the Umatilla Confederated Tribe, talking about integration of their behavioral health and their primary care services. And so there's a lot of movement and energy, and I thought this is a good group to come and say there's some opportunity. I think WICHE would be a good partner with that in terms of some of the expertise. I certainly have gained a lot of that over time, but it really requires a number of things. And as I've set up here, sort of the partnership with the state and the tribal nation. There's relationships with the federal entities, whether it's IHS as one, but also CMS and SAMHSA and other organizations who all sort of have a play in this. And there's a lot to learn, but I've fumbled and stumbled over the last 4 years in trying to figure those things out, because one thing I've learned in the Native communities is no to them means no and they stop. No to me is like, it's a challenge, get out of the way. I'm going to go to find this. And so culturally we approach things very differently, and I think that's where state partnerships can be helpful. We're at a time where we're looking at if it could be a tribal entity. Public Law 96 talks about in healthcare and Medicaid, an urban Indian setting, a tribal entity, which usually has to be a designated entity from the tribe to deliver services, or Indian Health Services. Most folks don't understand all the little pieces of that. The tribes themselves get caught up with what they believe is a federal trust, which is IHS. The federal trust is that IHS is going to meet your medical needs. And so they don't sign up, or don't do a very good job of signing up, especially the elders and the older folks, for Medicaid or Medicare, because they believe there's a federal trust that the government's going to take care of them. And in actuality, my experience is we've done sort of a disservice. We offer a bucket of money, they start a program, it gets spent, it gets shut down, they wait for the next bucket of money. And so part of this initiative is turning that revenue cycle from a bucket granted money to a bucket where you do the work, you bill, you get paid. And the cycle goes on, and we really change the revenue look of what can serve their community. There's issues around the state perspective in terms of, is it their responsibility? How many states have tribal or Indian affair offices that serve the governor and serve the nations and actually meet with the nations on a regular board? There's Indian Health, there's a National Indian Health Board. IHS has a behavioral health conference or association that meets. There's a lot of folks who are sort of in and around, but when you get to the groundwork and you walk into the community and you start, it's very much a process that takes time. I started 4 years ago with an entity, licensed 2 years ago, fought this entire last year with Medicaid in terms of payments. Whatever obstacle could come up, it's come up. In terms of just allowing a tribal-run licensed, with licensed providers, doing community work and outreach work and building cultural perspectives to that. There's a lot of things that can go wrong along the way. And then from a tribe, we're a sovereign nation. You know, we don't need to listen to what anybody else says. We don't need to have a relationship. In reality, to tap into and to utilize Medicaid and Medicare funds, you need to have the relationships and you need to have strong ones. So I'll just walk through a couple other points that I think are, we're at a time when healthcare is really, I'm probably talking to the choir, but the Affordable Care Act, Medicaid expansion, and then the one thing that I've seen really significant is tribes acknowledging they have a responsibility and they have a need, and are talking about it within their community, even to the point that in San Felipe Pueblo, New Mexico, we sat down with the tribal council and had an interpreter for a day-long meeting, talking about this and talking about it in their language, instead of the non-native language, their community language, and getting their elders to understand it and acknowledging it. And it's tricky here because tribes historically have had healing practices, and they're very reluctant to give it to another tribe, and especially a non-native. And so when you look at their community and the natural or traditional healing practices, and you want to build that into a continuum of care, they're not really very willing to talk about that. There was a study in Montana that was funded through, I think, a SAMHSA endeavor, where a Native woman went around to all the elders and all the tribes, collected all that data, was going to present it, and the Indian Affairs Division for the governor representing the tribes stopped it. Not going to share this information. This is private tribal information. So another kind of barrier that you run into, and then the fact that there are 50 states and there are 50 different Medicaid plans and 50 different people you got to talk to. And on the federal level, I can tell you more than 10 times I've run into, that's really above my pay grade, Dan, trying to get an answer, trying to find somebody who will champion this. Cindy Smith, CMS, Regional Office Denver, champion. Charlie, champion. I mean, take it on, march it up, find an answer. Been really helpful. On the tribal IHLS level, not so helpful. So why is there, what does the tribe need in order to do this? Here I'll just walk through a typical setting. I'm doing some work for the National Indian Child Welfare Association, whose job has been primarily to challenge child welfare issues at a state level, provide education, do legal fights, Baby Veronica most recently, but has a lot of system of care grants for tribal communities. So what they've learned is that early on they got to go in and find a way to have sustainability. So they'll get a $5-10 million grant for 3 to 6 years, and then over the course of that, it just fizzles out because there's no way to sustain it. In actuality, there is a way to sustain it. It's early on, develop the structure, understand the rules on a state level within the Public Law 96. I think I'm saying that one right. There's a couple others, but understanding those, begin to build the infrastructure, which often is they've never been in a situation where they build and had to document, build, collect, be responsible, accountable for that information, to have licensed people. IHS folks, many of you are aware that you can have your license in any state and work in any state as long as you're licensed. That makes you billable from a Medicaid standpoint. Try to find a licensed Native American PhD. Worked with a lot of PhDs. None that I've worked with have been licensed. So taking them past that, you're out of school and you got to go through this. But Nate and I were talking about how do you find somebody who's licensed who can provide supervision. So you have a licensed PhD, you have a licensed social worker, primary care person. So workforce issues. That early on, setting the structure and helping them to begin to identify what are the tasks in front of them. How do you operate a business is also an issue. So a lot of things early on. So in a system of care project, they're not only assessing their community, but over here building some infrastructure and understanding how to operationalize it so that they can get revenue coming in to support it. And it's a 3 to 5 year process, I will tell you that. And part of why I'm here today is that I think there's an opportunity to upstart this and to save the state money. One example, in Montana, I had the Medicaid Utilization Bureau do a review of children who were self-identified as Native American and how many Medicaid dollars have been spent in terms of the match and general fund dollars. It was over $1 million in 1 year for that group. And the question is, what would you do if you had another million? And we're a state of 1 million people, but our population of Native Americans is about 12 or 13%. So that's a huge dollar amount given that segment. But what would you do with the additional money? Where would you put it? And most states I've talked to, the money is everybody understands, but money talks. And if you can save money, and so I've gone to, if I can't get the Medicaid person's attention, I've gone to legislators because they're sensitive. And that sort of triggers people further up in this.
And that's an important part too, because I know when I was in Alaska, we did that, and it was very successful. I don't know if they're still doing it in Alaska now, but it did save money, just like you said.
Yeah, they have and they are, and it does save money.
Good.
And the initiatives up there are more sensitive in terms of, they're more culturally responsive and inclusive in what they do. Yeah.
So the one question we had when I was there in Alaska and we were doing that, in the villages, we were serving both the Native population, Alaska Native population, and the non-Native population. They're running all the money through 100%. And they were starting to question that a little bit.
Yeah, they will. It really is, they have to be a member. So so part of it is, and even in a community where you work to get those children or families who might be eligible to get eligible for Medicaid, some of the issues are, if you're identified as a social worker, guess what social workers do in tribal communities? Take kids away. So you're going to answer the door. You're going to work with them. It's just really, it's interesting kind of barriers that get in the way. But certainly, yeah, Corey.
You got state licensure issues up there. Have you been seeing that more recently in states? I know early this year, CMS really pushed down the rule, basically saying that they weren't going to pay for anything that wasn't licensed, right. And now states are running into that issue of trying to negotiate with the non-IHS 9638s to get the tribe to waive sovereignty for that little parcel of land or that process of surveys.
Yeah.
I don't know if any state is having a lot of success with that or if they're running into more barriers yet.
None that I know, Corey, and that is what I always do with the entities or the tribes I'm working with is to work to get licensed to the nth degree as if you were not a tribal entity. So get licensed at the state level. Make sure your staff are all licensed so that you cover all those. Because the non-IHS, non-638 folks, they're going to be able, they have to bill at the state rates.
Right, and then for the state to be able to go in and actually do the survey on tribal land, be able to issue the license, is where the problem is happening.
Yeah.
For the tribes, because the state isn't going to give a license that they can't enforce, and the tribes right now are balking at saying, we're not going to give up sovereignty. We're a sovereign nation, and so now you're in the middle of it, saying, well, then I can't pay you.
Yeah, 2 states, Montana didn't have any difficulty with that, although we fought for months over reimbursement issues, and New Mexico, the Mescalero Apache was able to establish a licensure, and they did it through a memo of understanding or agreement that was also connected to the managed care entity Optum in order to get reimbursed at the higher rate. But yeah, the enforceable piece of it, I haven't seen that challenge.
Would it somehow be a waiver to a state plan?
It's a good question. I wish Charlie was here.
CMS won't let it happen on a waiver to not have a license.
Yeah.
We put the request in to CMS to do that, and they're saying no, they've got to be a licensed entity. So it really does. It falls both at a federal level with CMS pushing down a regulation that they haven't necessarily needed. It's been working fine to the state level and the tribal level and trying to work that out. We've been trying to deal with it and just educating about contract language and things like that, and really looking at it as, look, it's a contract.
Yeah.
but we've got about half the tribes willing to do it, and the other half not. So I was just looking if there was a good model out there that a state or a tribal consortium has developed that says this is good and works for us.
Yeah, I think one of the issues you talked about is that contracting piece, and that's one that I would talk about further. The Goshute tribe in Utah actually has a pretty unique relationship with a provider entity that's non-native, but it's physician group doing their primary care, collecting at that highest rate, but the money routes through the tribe, through the Goshute.
So they're passing it through.
Passing it through, taking off an administrative piece. For 2 years, I've searched for just that kind of because IHS, we have no, IHS is telling me they have no previous or pre-existing situation that shows that you can do that. Although they contract with providers, with docs and nurses and specialty folks, but not.
They're basically doing a subcontract at 638.
Yes, yeah.
Is that what public health does? Isn't there something different with public health in terms of how they work with tribes? Or am I way off?
Public health. Well, public health. That's a good. I don't know the answer. I know more about the FQHC side of it and how they're recognized and the rules they have to follow there. But I could find out more about that piece. Right.
I don't know if there's a potential to try to look
Move
at
it
what
that
they've
way.
done and
Yeah. I don't know. I do think that we talk about all the different relationships, and I'm really interested, Carl and Corey, and your the Navajo have been really interesting. Their application to CMS to be their own Medicaid entity, and I know that it was moving along, but I don't know where it stands right at this moment.
It's just sitting out there in limbo right now.
I heard that it had to go to Congress actually to be passed. If the Navajo were able to be a managed Medicaid like a state, that could change and have repercussions across the other nations considerably. I know the woman who did the feasibility study. She and I have done some work together, and her recommendation was that they didn't have the capacity to do it. However, that was ignored.
Some of the contracts we have with them are really great.
Yeah, and I know some of the managed care companies are very interested in how they could work specifically with tribal communities, the American Indian, although none of them are stepping forward and going to dive into it. They asked me if I wanted to go in business with them, and I told them that's not my business, but I think that's important. I think the other thing is that we're talking about expanding their healthcare delivery system really from an IHS, where it's crisis and clinic-based environment, to community-based and outreach. And in order to capture that encounter rate, really, in order to do the outreach stuff, you have to have the encounter rate. It's expensive to outreach, to go out to where people are, because transportation is a huge issue in a reservation environment, as it is in a rural frontier environment. So getting them to the point that they can qualify for that encounter rate, meaning they have the right staff, which means maybe they have the encounters with people who are licensed, but they do other outreach and cultural activities with the excess funds. They're reinvesting in their healthcare system in terms of case management or traditional healing, whether it's a sweat or beading or singing or learning the language. You can build clinical appropriate activities within those activities. For billable, I was part of a equine therapy group in South Dakota with Brenda and I can't think of Brenda's last name, but Marley's White Hat. And within their equine group, there was a traditional person who told a story at the beginning about horses and their people, and then the therapist did a round robin about each kid who is there and the value of that and how they're thinking about that in terms of some of the struggles they're having. And then the horse, the equine person, the specialist out there with the horses walking through, and the therapist and stopping at certain points and taking some talk about it, and then coming back to a small group, and the therapist wrapping it up, and the culture person talking more about horses and how they put that in there. It's a very expensive little hour and a half with all the people involved in horses. On the same hand, it captured therapeutic work, cultural information, and put it into a good place. We've also done it with working with the elders, canoe trip. I mean, there's been a lot of really interesting things where we've done cultural and traditional practices and included a billable activity that used the encounter rate money to pay for some of those other things. And so that's part of it that you have to convince the council about, is that Medicaid dollars need to be reinvested in healthcare. So oftentimes tribal council may see $330 per encounter. It's a lot of money, and maybe move it over there. So you have to find a real champion or two on the healthcare council. And that's where I think the relationship with states is really important, to understand the value of reinvesting, prevention, those kinds of pieces. And most of them call them wellness centers. They're not going to call them mental health or behavioral health. They're wellness centers or healing centers. So I don't need to tell you about budgets and money and all that. Those are all good reasons to be doing this. Finding out one way you could sort of see, is this an issue? Is there some way we could do it? Is really to look at your utilization and your state match in terms of Medicaid, and isolate that out and say, here's the money we're spending for individuals who are recognized tribal members, and to be able to reinvest that, I think, in an initiative to create a dialogue with a tribal community and say, would you like some assistance? The opportunity's there, and I'm finding that the workers are there. It takes time to do the workforce development. University of North Dakota has developed a center of excellence for psychologists. Nate and I were talking about some other institutions that were developing workforce. And then you have your peer community. So a peer specialist is somebody who has a lived experience in terms of mental health. Many tribal communities, when I say and try to find out what the percent of statistics on mental illness within their community, they'll say, well, we have 100% post-traumatic stress disorder. And I try to peel that down, and that's relative to the historical trauma that they identify with, and most times it's not going to meet the clinical criteria for PTSD. But try to find out good data on American Indian, Alaska Native populations in terms of mental illness, and there just isn't good data. We've not collected, so we don't know a lot about it, but most of them will identify with PTSD, substance abuse, suicides, depression, attention deficit in the schools, whatever else the diagnoses may be. Perspective of community-based and outreach, I think, is, and we just talked through that. A couple of interesting projects, the Umatilla Confederated Tribes in Pendleton, and then I just signed a contract to do some work with United Tribes Technical College in Bismarck, North Dakota, who has a clinic. They have a campus of about, I suppose there's 1,500, I'm sorry, students on campus, and then have families. So we figured about 5,000 is their end in terms of people who might seek services, but they want to turn their healthcare clinic into not only healthcare, but mental health, substance use. They're owned by 5 tribes, so the challenge becomes, will those tribes designate the college as a 638 contracted kind of facility, and that makes them eligible for that higher rate? So there's lots of little challenges down the road, the most stringent rules around substance abuse providers being licensed, and then being a program who's licensed. So we have a lot of challenges, but I have a peer of mine who's Native and a licensed addiction counselor and somebody who's run many treatment programs. So he's chasing that, and I'm chasing some of the other pieces. And unique challenges in San Francisco's city of Richmond on the urban side. The issue there is the county, Contra Costa County, doesn't know if they want to contract because they don't know if the center, the urban center, has the capacity to meet all the criteria and the rules. So that's a constant one. You know, we could license them, but could they really do this? And that's the importance of the front end work, is to really, and to have that partnership. Like the county's really involved. I've been so thankful to them that they right there at every meeting, they're like, okay, no, that's not what we need to do. We need to do this. Then they call me later and say, do you think we're really going to be able to pull this off? And it's a good question. It's a good, because these are challenges. Detroit Wayne County, who's failing financially, the county of Wayne County, but they have the American Indian Family Services Center has presenting to their center 250 different tribes, members of tribes, but yet they relate to the Bemidji Area Indian Health Services Office. That's where they get their 638 contract. And they can't bill Medicaid outside of just members because they're not certified with the Behavioral Health Authority within. So that's my goal with them, is working with them to get certified. So non-natives who come or who maybe don't meet the membership requirement can bill Medicaid, not at the counter rate, but certainly they now have a payer source. So lots of things that go on. So what can you do? Really, I think in a nutshell, really evaluate your relationships with those tribal entities. Is there an ongoing group that meets? South Dakota, I know, I've read the minutes to the behavioral health group. Oregon, you have, I always say Oregon, sorry. Oregon, you have a group, I've read the minutes there. Some states do it, there's a National Indian Health Board that has some responsibility, but I think it's just starting the conversation. If it would save you money, the state, would you be interested in engaging in that conversation, and with the idea that maybe you could repurpose some of those Medicaid dollars in some capacity? And that's where I always pull in some legislators, because they're really helpful for supporting. If we save money here, we want to keep it in the healthcare side and the behavioral health side. I think the other thing is, as Dennis has talked about this morning, is that WICHE as an ally, as an entity who could be helpful. I think that's important. The communities themselves, I've found, I've had to be invited. I can't go in and sell it. It's never worked, even in the one I grew up in. It changes from another challenge tribes have is they change their elected council annually. Sometimes it's every 2 years, but mostly annually, and you find that you're starting over at times. So learning their system, like get a resolution, a tribal resolution, which is like very important, and it stands. Despite the council who did it, they'd have to do another resolution to undo it. But early on, get the tribe to stand and do a resolution in support of the activity, understanding the relationships, permitting an agreement between maybe IHS and a tribal-run wellness center to negotiate and have a subcontract to deliver sort of community-based and outreach services. There's a lot of little things like that again, if you don't live in that environment and understand it, you run into it, and then you got to do it. Some hard work there, but I'd say I have about 20 communities right now, urban to rural to Nebraska's a challenge. I will tell you that they really want to do something, but their communities are spread out. I've approached in Nebraska. I've approached Magellan, who has the the MCO contract there to see if we couldn't find a way to use some of their reinvestment dollars that they have available to take one community and see if we couldn't work with them. Because I think there's a lot of ways to go at this. But I'm going to stop talking. Thank you for giving me an opportunity to share the work. And again, if there's questions, I'm happy to answer what I know and do the research in terms of what I don't know.
Dan, one of the things that we found in the last year is, because we contract with 6 tribes in Arizona to be their own regional behavioral health authorities.
Great.
And we formerly had all of our contracts with all the same deliverables as we had for every other regional behavioral health authority. I asked our contract team to strip those contracts down to the bare bones to only meet what was truly required and reportable for, whether it be CMS, any of our grants or anything like that. So we could start, instead of having continual corrective action plans and failures and failures and failures year after year, we could start building on the success of meeting the basics. And part of our deal was we're always pulling their administrative funds back because they weren't accounting for it right. So instead of giving them their administrative funds and then pulling them back, we started the process of having them earn them and paying them on a monthly basis out. And that has made such a difference in the last year with our relationships with those tribes. They've been able to advance because they don't, it's turned a negative relationship into a positive relationship. So some of the very basic things, I think, are what we have to get down to sometimes to build those relationships and the trust together.
I think you hit it right on the head, Corey, that their experience with the non-native world and the historical trauma is that it's overwhelmed, they're going to fail. I mean, that's really how they approach it. So having it on a win-win kind of keep it simple basis really does work. And I know when I do the consultations, I'll go in for a couple days, assess their capacity, look at sort of the rules, look at the state rules, find some context there, and then start doing it. And I can give the presentation. And I don't give PowerPoints anymore, I give Prezi presentations to them. Because culturally, being able to see the whole thing makes more sense. But I can give the information. I can tell you I have to go back and I have to say, okay, let's take step 1, because it's not their experience. They're not been mental health directors. They've not worked in the non-native communities. So it's a different, takes time, moves at a different pace.
There's a whole trust factor.
Trust, yeah. You have to listen. I always think of Covey: seek first to understand and then be understood. And that's my approach with all of them, because I don't say anything unless I'm invited to. At the end, they'll say, "What do you think?" And so learning that and doing what you say you're going to do, incredibly important with them. Well, great, thank you.